need to understand the forearm as a joint, the concept of forearm as a joint, which is formed by the radius and the ulna. So there are two bones with 5 joints and 8 movements occurring between radius and ulna at the forearm, at the elbow as well as the wrist. So if any break in the continuity of this as a joint can lead to disruption of the orientation of the radius and ulna and adjacent joints as well. So we can see this fracture here of the ulna. So if you see the fracture of the ulna, you see that the radius also is dislocated. So two important lines is we have to remember when we are seeing a forearm fracture, especially when you suspect a Monteggia fracture, the ulnar bow line and the radiocapitular line. So the ulnar bow line, the radiocapitular line is morning what we saw. If you draw a line along the proximal radius, it should point to the center of the capitulum in whatever degree of flexion the elbow is. And another line is the ulnar bow line described by Lincoln and Mubarak. If you draw a line from the proximal metaphysis to the distal metaphysis, so there should be less than 1 mm of deviation. If there is any deviation, that means there will be an associated disruption of the proximal radial ulnar joint. So you see there, there's a radial head dislocated. So what we see, a isolated radial head dislocation actually is a Monteggia lesion here. Okay. So where do pitfalls happen, especially in acute ones? The borderline diagnosing borderline Monteggia lesions and its variants, we tend to miss the lesion as such. And at the time of treatment, inadequate reduction of or fixation of the ulna can lead to inadequate reduction initially, or if the fixation is inadequate, subsequent displacement can happen. That's what I call it as a gradual displacement. So all these can lead to chronic Monteggia lesions, which is much more difficult to treat compared to acute setting. So I'll just touch on acute Monteggia lesions. We know the Bados classification. So type 1 is more common compared to an adult, where type 2 is next common. In children, type 3 is more common. So we need to remember these modifications and the variants of these Monteggia lesions. I'm just running through because of short of time. So the Monteggia equivalents, what we call isolated radial head dislocation or associated fracture of radius and radial neck fracture. Okay. So this type 4 variant was described by Professor Wilkes. So there's a segmental fracture of the ulna along with a radial neck fracture. So it was treated with an intramedullary device. Okay. So as I said, you have to remember two important lines: the ulnar ball, the ulnar capita, what do you mean? The radiocapitular line and the ulnar bow line. So if there is any disruption, that means there's a Monteggia lesion. So these different variants of Monteggia lesions can happen. Okay, so these different variants, and you can see the equivalents as well here. So we need to be able to pick up all these things and treat accordingly to prevent chronic Monteggia lesions. So it is the character of the ulnar fracture rather than the direction of the radial head dislocation which directs the optimal treatment of these Monteggia lesions. Okay, so a stable anatomical reduction of the fracture results in anatomical reduction of the radial head. So this is what forms the basis of treatment of all these Monteggia lesions. So what is the best treatment? So simple, if it's a plastic deformation, you correct the bowing under anesthesia and do a casting. So you don't need to specifically reduce the radial head. Once you correct the ulna, the radius falls back in place. So if it's a green stick fracture, again do a close reduction and the radial head will fall back in place, and you do a good casting. So whenever there is a transverse or a short oblique fracture, you can put an intramedullary device. Only if it's a long oblique or a completed fracture, you need to stabilize with a plate. Okay. So type 1, you correct the bowing. This is what, especially when there is a plastic deformation or a green stick fracture, you correct the angulation, the radius falls back in place, and you can put a cast in with the forearm in supination and elbow in hyperflexion. Only problem with this cast treatment is when there's a setting of lot of swelling, you will not be able to hyperflex the elbow because of the swelling, which can lead to vascular compromise and compartment syndrome. So type 2 lesions are reduced and immobilized in extension. So type 3 lesions, you correct the varus deformity, radial head will get reduced back in place, and you put a cast in a neutral position. So when treated in a cast, as I said, there's a tendency for redisplacement. This is because of the pull by the muscle forces. See, you can see this illustration. This is actually by Professor K. Wilkins. You can see initially it was aligned well, then gradually it started to angulate laterally and radial head started to lateralize. So here the ulnar fracture was, osteoclasis was done and intramedullary fixation was done, and the fixation was stable, and radial head you can see that it's gone back to its position. So what happens in a cast is the ulna can get angulated posteriorly by the pull of the triceps, and there can be radial deviation of the ulna by the pull of the common flexors. So this can gradually displace the radial head anteriorly or laterally. So solution is a well-mounted cast, and if you think there's a lot of swelling, you need to go back and recast the child after assessing after a week or so after the swelling subsides. Other solution is to put an intramedullary fixation. So the aim basically is to provide a stable ulna. If the ulna is stable, the radial head will be located. So this is a type 1 variant in a 11-year ball. You can see the proximal third shaft of the radius along with radial neck fracture. What we did was, because I had to restore the restoration of length and alignment of the ulna is very important. Once the moment you see, I just put one screw on either side, the ulna was stable, the radial head was back in its position. We just supplemented it with a intramedullary wire. In subsequent similar case, I didn't even use the intramedullary wire, it was quite stable. Okay. So this went on to heal well. So a good outcome for Monteggia lesion in children requires early diagnosis and stable anatomical reduction of the ulnar fracture. So take home message is, do not miss an acute Monteggia lesions. Simple is, you take a full forearm X-ray and draw those two lines. And we have to identify the equivalents of plastic deformation where it can cause isolated radial head dislocation. And key is to restore the length of the ulna and alignment of the ulna. Thank you.